Welcome everyone to today's webinar. My name is Rebecca On, and as today's moderator, I sincerely welcome all of you to our platform. Today's webinar topic is on improving your ridge augmentation and immediate implant techniques using laminar bone and allografts. I would like to inform you all that you will be receiving a total of 1 CE credit. You must stay active during the whole session, and at the end of the webinar, a pop-up window of a survey will appear on your screen. If you do not see a pop-up, you will also be receiving an email from GoToWebinar with the survey link an hour after the webinar has ended. You will receive your CE certificate by email within 14 business days. As shown on the screen, there will be a question box in the panel board. Please feel free to ask questions in the question box throughout the lecture, as the presenter will address them during the live Q&A session after the lecture. Without further ado, I am honored to introduce our speaker for today. Dr. Daniel Thousand attended undergrad at the University of Colorado Boulder and graduated with a degree in integrative physiology. He then graduated from the University of Colorado School of Dental Medicine. After graduation, he continued his education at the University of Colorado School of Dental Medicine to receive his postdoctoral certification in advanced periodontal, implant, and surgical dentistry. He is passionate about providing the best patient care possible and participating in continuing education in all fields of oral health care. With that, I ask that you give Dr. Daniel Thousand a warm welcome to this webinar.
Okay, so hi guys, how's everybody doing? I hope everybody can kind of see my screen if it's being shared. I'm sure Ellie or Rebecca will let me know if that's not the case. Anyway, I wanted to say hello to everybody and hope everybody's staying happy and healthy and getting back their practices and getting everything kind of up and running since the last, here we go. Oh, yep, there's my face. Just wanted to say hello, everybody. Thank you for that introduction, Rebecca, and I hope everybody's staying happy and healthy and your practices are kind of up and running and everybody's getting back to at least maybe a normal schedule. I wanted to thank everybody for coming out and taking some time, whether or not you're interested in this topic or you're just interested in the CE credit and you're having a beer and I'm in the background. Regardless, thank you for kind of taking the time and part of your night to do this. I'm hoping that everybody is back and busy and profiting from after this COVID epidemic. So really, another thank you would want to go out to Ryan Marteris from Regenetics for setting this up and letting me kind of take an opportunity to present some of the results that I've gotten from utilizing the laminar bone membrane and allografts from Maxius, because truly some of the results that I've been seeing from this over the last year and a half are pretty amazing, and I'm happy that I can take some time to share everything with you guys. So I know that Rebecca's already kind of introduced me a little bit, but originally I am from Saudi Arabia. I know my complexion probably screams that. So if you were thinking to yourself, yeah, he looks like he is from the Middle East, well, you're correct. I was born there and moved to Denver, Colorado when I was 10. I attended the University School of Dental Medicine here, and then my postdoc in periodontal surgery here as well. Currently, I am in private practice, and I've been in private practice now for about 2 years with Periodontal Associates. We have 2 locations in Aurora and Littleton, and I practice in the Littleton location. In about a month, I'll become a partner. But outside the office, I do like to ski, and I like to rock climb. I like to kind of do backcountry if at all possible. I also like to travel a little bit. And my girlfriend and I rock climb together kind of throughout the world wherever we can find places. And oddly enough, this last winter we found a place in Cayman Islands of all places to go rock climb, and that's just kind of a photo of one of the cool sunsets. We also just bought a little corgi, so a little more about me, and she kind of takes up all of our time for now. So not doing too much rock climbing, just kind of working and taking care of this little nugget. So kind of tonight's outline, really I just wanted to give a brief background of the laminar bone membrane and kind of, it is really brief, but kind of how it got its start and where it is now. I also wanted to talk about some of the properties and the handling characteristics of the laminar bone membrane itself, And allografts are pretty self-explanatory, but I'll talk a little bit about the allograft as well. I'd like to go over some of the pros and cons of the membrane itself and how to use it in conjunction with the allograft, and some little tips and techniques that I've learned along the way with using this over the last year and a half. I'd also like to then kind of move and shift into presenting some of my cases, and just really a few of the brief techniques that I use when augmenting ridges or improving my socket preservation, whether there be a facial bone plate loss or a lingual bone plate loss. Give you guys a summary of kind of what I'm seeing, and again, I don't have histological evidence, so there's some grain of salt to be taken with this, but I was always told in residency that if it looks like bone and it smells like bone, it's probably bone. And again, so with that being said, you'll kind of see some of the photos that I've taken, and some of the radiographs and cone beam CAT scans that I've taken, that will show kind of the results that we've been getting from these membranes. And then just kind of go over, have a Q&A session if you guys have any questions on how this works, and hopefully I can answer some questions for you guys, and you guys can utilize this in your practices and maybe take something away from this hour. So before I start, just a little bit of a disclaimer. I don't work for, nor am I paid or supported by Regenetics or Maxius's companies. This lecture and photos are of my own property, and depict surgical cases, and unfortunately sometimes poorly, which is why I'm going to go through them with you. And I don't claim to be an expert by any means of this material. I have just utilized it a decent amount now. I'm just a humble periodontist, and I just kind of want to try and share some of my successes with the greater dental community, so we can provide those benefits to our patients. Again, this is my first webinar, so I'm kind of just talking to a computer, so if I move my eyes around or if I curse, I'm sorry. It has nothing to do with Regenetics or Maxius's companies, but really just kind of, it's weird to talk to a computer screen by myself. Normally, I would lecture in front of people, and regionally and around Colorado or at study clubs, so this is a first for me, so thanks for bearing with me, guys. Anyway, a little bit about the background of the laminar membrane. Maxius Dental Biologics have really been around since the early 90s, and the laminar bone membrane was around at that time period, but due to the obtaining of them from the femur donor and donors that from femurs of the donors, difficulty in processing and handling procedures made recovering the grafts difficult. So utilizing the membranes and getting them out into production for people to use was quite difficult. But when they were in use, and again, in late 2018, Maxius has now launched the laminar bone membrane. But when we were using these in the past, they were showing quite positive results that were comparative to the traditional way to gain vertical or horizontal guided bone regeneration, and in using PTFE membranes. But the PTFE membranes would have to be removed. A lot of the times they would fenestrate and could be catastrophic failure to the bone regeneration. When the laminar plates were used, there's no reason to remove the actual plate. And so the results that they were seeing were quite comparable and promising. As far as for my standpoint, new clinical observations from me and others would probably support prior results to this regeneration, and that the laminar bone plate is quite capable of creating all of the things that you would want from a PTFE membrane without the need to retrieve it. The Maxius dental allografts have shown extremely high success. I mean, I've been using those since the beginning of my residency, so I've been using those for almost 6 years now, and they've always shown extremely high success rates in regenerating deficient oral bony ridges, whether they be for ridge augmentation or for socket preservation. Maxius has, continuously been on the forefront of oral hard tissue regeneration, really kind of since allografts became viable in the dental field. They've been around. So, kind of going into a little bit of the properties of the membrane, and these are kind of my guidelines, and they're similar to what product inserts would tell you, but I like to just go a little bit further into it, and some of those would be the indications of use for me. Would always be when I need structural support. So if I'm missing a lingual bone plate or a buccal bone plate, or if I'm trying to gain vertical or horizontal bone, structural support is extremely important. In the past, titanium mesh, as well as titanium reinforced PTFE membranes, were kind of the only thing that were really predictable in terms of success to get that a large volume of bone. And so something that has structural support when you're doing procedures to gain vertical or horizontal bone, when you're augmenting bone, that is very important. When you want space maintenance, so again, when you're trying to utilize a technique to get vertical or horizontal bone regeneration, you want something that's going to maintain space for a long time and help reduce pressure on the graft under the membrane after it's closed. And for me, obviously, now that I've been using laminar bone membranes for quite some time, this is kind of a no-brainer, but retrieval is not desired. And in certain situations, you know, a titanium mesh membrane or a titanium reinforced PTFE membrane are beneficial, and I still do use those from time to time, but the usage is getting less and less as I get better and better with utilizing the laminar bone membranes. And I'll show you guys some cases here coming up on how I use them, and you can truly see how you can utilize them in a lot of different situations. So some of the advantages that I see, obviously, that it naturally resorbs, and they don't say this in the product insert, but I've tended to see that it actually, depending on, you know, if you cover it with something else or if you know, the patient doesn't resorb the bone a lot, it tends to actually integrate into your graft. It can be tacked in place with screws or pins, or it can be sutured into place. So the versatility of adhering and fixating the membrane is quite large. It's trimmable with scissors or a scalpel, and I tend to use, I found that you know, scissors work just fine, but the scalpel is a little more useful when you're making precise cuts, when you're trying to form the membrane around a ridge and teeth. So typically I will use a scalpel, and I'll use that especially to make final modifications after the membrane's in place. No rehydration is required. I know that's kind of a simple step for most collagen membranes. They don't really require a lot of rehydration, so it's not really that big of a deal. But that extra step is nice to not to have. However, recently, probably the last 6 or 7 cases that I have done utilizing the laminar bone plate, I've actually soaked the membrane in PRF for about 10 minutes prior to placement, just to kind of give it another little biological barrier with the patient's own platelets to allow maybe some bacterial inhibition and maybe some earlier healing. It comes in a bunch of different dimensions. The smallest one is the 1 by 1 centimeter, and typically I'm using that in situations where I'm just missing one plate, facial or lingual. The 1.5 by 2 centimeter is typically my workhorse. I see a lot of cases that come in missing facial and lingual bone, and so typically I'm cutting this in half and utilizing it, or stretching it over the actual socket. It just kind of depends on how deep the defect is and what type of regeneration I'm looking for, and whether or not I'm placing an implant with an immediate implant after the extraction, or during guided bone regeneration, or if I am just planning on regenerating the socket and coming back later. And then the last one is a 2 by 3, and it's a pretty large membrane, and I utilize these in my vertical and horizontal guided bone regeneration cases. So, and I've got one of those that I'll show you guys as well. So some of the pros and cons of the laminar membrane. There's a lot of pros, but there's also cons, as to everything in the dentistry. So first I'll go through some of the pros, and the pros would be that it handles like a dense PTFE membrane. And it's actually a con too, but I'll describe that later. So the handling and utilizing it like a PTFE membrane is that you can put it in place, and as long as it is fixated, it will stay fixated, as long as it's properly fixated. It can be left exposed depending on the situation, depending on the patient. it can be left exposed, and you can expect minimal bone loss, minimal volume of that bone to be lost. And when you're uncovering it, or you're uncovering an implant that's been placed at the same time, you don't see a lot of granulated tissue at the coronal aspect of your graft. It slowly resorbs to allow for really, really good graft consolidation. Typically, I wait about 6 months in anything vertical or horizontal. I have waited less time, and I've been very pleased with it as well. But just to be on the safe side, and depending on the patient, elderly patients or patients that have systemic complications, I tend to wait a little bit longer. It's much easier to remove from the periosteum than most collagen membranes. Depending on the type of membrane, whether or not it's cross-linked or not, when you are going for flap elevation around those collagen membranes, sometimes the collagen can be incorporated into your graft, and if you're not careful, you can actually rupture some of the graft material before you even go to place implants. And I've found that when you are reflecting your flap after you've used the laminar bone membrane, the periosteum comes off quite easily. There is some small degree of bacterial resistance as long as it's maintained by the patient. If the patient's not maintaining it and they're getting plaque on the actual membrane, it can actually be a downside. There's excellent space maintenance over 6 months. I haven't left anything really longer than 6 months, but I would assume that if it is not resorbed or it has not integrated, that the space maintenance is going to be kept for quite a long time. Another pro would be that it is, the allografts and the laminar bone plate itself are somewhat osteoconductive. And so if you are utilizing PRF or some other growth factor in there, even that you don't need to, you're going to get robust bone growth. So again, some of the cons, and again, like I said, it handles like a dense PTFE membrane. If you're not familiar with how the product actually works, and you haven't kind of tested it out and played around with it, it does have quite a bit of memory. So it wants to go straight and go back to the form that it was on the long bone where it's harvested from. So with that being said, you really need to know where you're going to fixate it, how you're going to fixate it, and keep it that way so that you know that it's going to stay in the same form. So just kind of some user error when you start using these. Inexperience in tacking can also lead to membrane splitting. I know the first case that I did, I was tacking this without any pilot holes, and the membrane can actually split if you tack it too close to the edges. So if you are planning on using something like an auto tack kit in the maxilla, or if you're using like the Meisinger tack kit, be cautious, and I would advise that you make pilot holes prior to tacking the membrane in. And if you do that, it works extremely well. But if you don't, you could subject yourself to having the membrane split. If the membrane is not properly secured, there is a high risk of membrane expulsion, meaning that the membrane can actually come loose from the tissue and you can lose your graft. I have never had that happen, but I do have other colleagues that have utilized this, and they have said that that has happened to them. So really just being careful, and it comes back to the technique of fixating this membrane just to make sure that that does not happen. It does have minor resorption over time, and so in big guided bone regeneration cases, I typically would tend to use some xenograft as well to account for some of that resorption over time. If it's left exposed and not properly cared for, like I said before, it can actually act as a nidus for bacterial growth, and then you can see some of the membrane kind of exfoliate on its own. But typically when that happens, depending on the point in time that it happens, the graft really stays nice and consolidated, and you don't see that many problems even if that happens. And then last but not least, still not 100% idiot-proof yet. Obviously, they're coming out with new ways to utilize this and methods and materials that will make it better over time, but still not idiot-proof. Okay, so that kind of gives us a little background and maybe some tidbits to help you when you start utilizing this, whether or not you're using it already or not. Hopefully that helps, and I'll kind of continue to interject some of these as I go. So I kind of want to go in an order of kind of the first case to the last case, I also want to mention some of the cases that I've done and really didn't document extremely well, but I do have radiographs and some photos that can show you that things are predictable. So the first case will be a guided vertical and horizontal bone regeneration case. Then we'll kind of get it into doing regeneration after you've taken an implant out per se, because that's a little bit different of a scenario. Doing socket preservations with just facial loss during immediate implant placement, or doing it with both facial and lingual facial and lingual bone loss when you're placing an implant. Doing guided vertical and horizontal bone regeneration while you're placing an implant after it's been taken out and you have lots of bone loss. And then the last one will just kind of be some bigger guided bone regeneration cases that I've done. So the first case, this patient had come to me from a previous practice that had taken the tooth out, and they had placed an Ossix bone plug, I believe is what she had told me, and that's kind of what her records had said. But the bone plug, I think, maybe had gotten infected, and she ended up losing quite a bit, as you can see on our pano film here of her CBCT. Quite a bit of bone was lost in the buccal and lingual dimension. And then if you look at our cross-sectional images here, we can actually see that she's lost, I mean, pretty much all of her buccal and lingual plate at site number 14. There was also a small sinus perforation that was present, and we'll kind of get to that later. That's not really that important right now. So the first couple of photos that I have here, I do apologize, are not great photos, but basically this is good to show us that we're missing quite a bit of the buccal plate here. And the second one to show you that, I mean, almost all of that lingual plate is gone, buccal plate is gone. She does have significantly high bony peaks on the mesial aspect of tooth number 15 and the distal aspect of tooth number 13, and that's going to play a big role in some of the success that we find here. This photo kind of just depicts, and this was the first case I ever did, so I never really planned on documenting this extremely well until I found out how well it was actually going to do. So my first photos here aren't 100% excellent. But I did start by tacking this, and you can kind of see our Meisinger tacks here and here, allograft, and then if you're wondering what went over the top, it was just a PRF membrane. And then this next picture kind of depicts our primary closure, our tension-free primary closure over that wound site. So we let the wound heal for about 6 months, and we got her back and took another CBCT. And on the CBCT, you can kind of see where the tacks are, and that we've gotten quite a bit of that vertical bone back. And then if you take a look at the cross-sectional images, we can see that we've actually gotten almost all of the horizontal bone back. Unfortunately for the patient, it was still only about 7 millimeters of vertical bone, so a vertical sinus augmentation was performed at the same time an implant was placed. So at uncovery, we can see that we have nice consolidated bone here. And again, you can also kind of see some of the I guess you would call them striations of the laminar bone plate there that are still present after 6 months, and that's fairly common. I see that quite often. This is with an implant placed. We can kind of see then here from a side view where the tacks still are, and you can see again some of the striations from the laminar bone plate integrating and incorporating into our bone graft. The site was then sutured, and she returned to her general dentist and had a crown placed, and that's been present in her mouth now for about a year. So our second case here is a case where there was an implant that had been placed, a failing implant with peri-implantitis, bone loss to around the middle thread, both buccal and lingual plate bone loss. There was a cantilever prosthetic that was placed on the top, and really the true reason I think that this implant had been failing is, one, improper bone maintenance or building prior to the implant placement. And there was absolutely no soft tissue. So quite a bit of inflammation was present when this implant was removed. And we'll see that kind of as we come up. So this is a picture just of removal. And again, I'm sorry, my pictures are not 100% great, but it does the job you can see that there's quite a bit of lingual bone plate loss here. And I mean, so much buccal bone plate loss here that you can't even see any of the bony peaks on either side. This gives kind of a good overview to see, again, the massive amount of lingual bone plate loss and buccal bone plate loss. And unfortunately, I did not take a photo of the membrane in place, so you're gonna have to take my word for it, but this is after healing for about 3 weeks. And then an x-ray then at 3 weeks, we can see that we have a pretty nice bony height here, primary closure maintained, and soft tissue volume looks relatively good. So we waited for him to heal for about 6 months, and this is just a coronal slice view of the CBCT scan that was taken on him. And then this is just a cross-sectional view showing where our bone is now. So at uncovery, this is what the bone looked like, and I don't have a close-up view kind of what the striations look like again, but if you really move the tissue out of the way, you can see them there. But we can see that we have unbelievably good height gain on the bone here. It's pretty much completely back to biological levels. And this is just showing the width that's obtained. Now we have an excellent site to place our implant in a correct position. And that is with the implant in place, cantilever bridge planned again. 2 implants could have been possible. Personally, I don't think that's a very good idea in a space this small. Cleanliness of this implant is very important in its long-term success. So soft tissue is still very, very minimal at this point. So a connective tissue graft was done, and then everything kind of sutured in place with the healing abutment tacking that connective tissue graft down. And this is a picture of the x-ray before it was sent off to the general dentist. Implant placed slightly in a different position, instead of the position it was in already, because the bone height was slightly higher on that side. So if you're wondering why I switched sides, that's why. So the third case is our classic case of external root resorption on an anterior central. The patient had also broken the tooth, as you can see kind of here with some of the fracturing. This is how the patient presented to me with a fenestration, a fistula kind of coming present through the gum tissue here. And the crown height, if you notice, is already higher than its contralateral tooth. This is just a cross-sectional image from our CBCT scan, and we can see that there is quite a bit of facial plate loss here, roughly to about here. So we take the patient to procedure, and we flap an elevator flap, and we can see here how much of that buccal bone plate is actually lost. And a lot of people here would probably say, well, let's try and regenerate that bone prior to placing an implant. But with the success I've had from utilizing the laminar bone plate, I feel very confident in continuing forward with an immediate implant placement. And so that's what you see next. You see the implant in place. You can also see that, it's lost to about the 6th thread of the implant, and the implant's a 12 millimeter, could have been a 14 millimeter implant as well. So we can see that quite a bit is gone. We want to regenerate, obviously, all of that plate so that we can get a good crown contour at the end. And so here is when I started really suturing everything into place and really getting my technique for doing that. The biggest thing that is important when you're trying to suture these membranes into place is that you have I call it a periosteal pocket, but really when you were elevating your flap, you want to do a full thickness flap I typically do a full thickness flap for about 7 or 8 millimeters, and then I stop and I actually start to do a periosteal release at that point. Then after I've done my release and I know that I can get primary closure if I'd like to, or at least something that's passive if I'm leaving it open, I can then go back and create that little periosteal pocket, which would kind of be up under here. And I can show you guys in another photo what it looks like. And then I create a sling suture through that, and then I use that to adhere the membrane in place. And in this case, I decided to leave the implant exposed, which you can see here. And that's with the implant in place. So she came back to us probably about 6 weeks ago, so she doesn't have a temporary on there yet, but implant in place, and we've actually kind of extended over the original crown margins. So we're going to have to do a gingivectomy after the final crown placement, or when she's in temporization or proposalization. That's probably when I will do that. And then this is, again, at 3 months of healing. Our fourth case, so this is a case that presented with both the buccal and lingual plate being missing, and this is just the radiograph prior. This is an image from the CBCT machine, and you can see that this image shows that he's got quite a bit of that facial plate loss. Also, a significant amount of lingual plate loss, obviously not as bad as the facial plate loss there. After the tooth was removed, this is kind of where we can see that quite a bit of missing facial plate loss in some of the lingual as well. So we decided to place an implant knowing that we have the benefit of using the laminar bone membrane. So I placed my implant, and again, you can kind of see quite a bit of how many threads are truly exposed there. And then we put our membrane in place, suture it into place. And there's also one that is sutured on the lingual in that aspect. And then in this case, the implant wasn't as stable as I would have liked, so I obtained primary closure on it. And then this is with everything sutured closed. And again, I was not a big fan of placing this type of provisional restoration on this patient, but he was insistent he did not want anything removable. So we splinted a tooth in place, and I did not do this part either. He came to me back this way, and he had been losing the tooth a couple of times, and I said we should do a removable, but he did not want to. So he continued to put it in place, and again, that's ugly. I'm not a big fan of it, but what I do want you to pay attention to, and this is after I had cleaned, he had some calculus that had built up, but I do want you to pay attention to the soft tissue heights are still quite good. And then we can also see that we have quite a bit of tissue at the lingual and buccal, and everything looks quite healthy. We remove the tissue, move it out of the way. I like to be very conservative when I'm doing this because I don't want to alter any of the soft tissue if I don't have to. And so we can see our bone heights are very nice there. We do have a little bit of bone loss here at the top, but either way, that's the soft tissue, and everything in that situation is going to turn out just fine. So we did do a connective tissue graft as well, and I plumped that tissue out just a little bit and suture everything into place. And that's just an occlusal view. And that's what the implant then looks like then after 3 months, with the provisional restoration that I really hate on there. And he should be coming back to us here pretty soon for a crown. So a kind of a common theme that you guys are going to see with my cases is these are all pretty new. And so a lot of them don't have the final restoration present yet. So if we had touched on this in maybe 6 months to a year, I'd have all the final cases to show, but that's not where we're at right now, and COVID-19 hit, so we're presenting it now. Another case that was done utilizing this bone membrane was kind of an all-on-4, or I like to call it an all-on-X type procedure, where a hybrid actually was not placed day of, but just based off of the pano that you can see, there's quite a bit of bone loss around a lot of the dentition. So terminal dentition, and the patient has elected then to place implants, and if stable, convert to a hybrid. But since so much bone loss was present, that was not really anticipated. And this is just kind of a little view showing that the defects that were present after the teeth were removed. And this is obviously prior, but we'll have some photos to show you what that looks like. And again, you can see the really massive defect here. And so when I see these and I'm treatment planning, the first thing that comes to my mind is, okay, which size of the laminar bone membrane am I going to use to cover this? Because my results have been so successful as of late that I really feel extremely confident going into the surgery, knowing just the size of membrane that I'm going to use, and knowing that the results that I'm going to obtain are going to be quite good. So this is how the patient presented day of. This is after removal and implant placement, so all our fixtures are in place. And again, we can see the defects that are present, just very, very large. Fortunately, he does still have pretty good bone height, so that's also going to play a little bit of a role into our success there. And this is with our allograft in place, and we utilized one of the larger 2 by 3 centimeter membranes for this case. The implants were also done simultaneously with sinus augmentation, and so a hybrid was not placed day of. The patient then came back 3.5 months later to have the implants uncovered. And this is just a view, an occlusal view of what those implants, but you can notice that we still see some of the laminar plate up in here, which is always amazing to me. I love seeing that. And some of it has kind of stripped off maybe into the periosteum a little bit, but our regeneration of the defect is amazing. Sutured. And then this is a pano film. You can see that the simultaneous bilateral sinus augmentation was done, and the ridge augmentation at the same time. So truly a remarkable case, and showing the good results that were obtained from it. Apologize, this says case 5, but this is actually another case. This patient presented with a failing implant, and the implant had been tried to, I think someone had tried to graft it, as well as treat it with a laser, and you can kind of see some of the unincorporated bone graft material here, and quite a bit of bone loss. And when you see these, you just cringe, and it's unfortunate because it's in a patient that is very aesthetically driven. She has crowns from number 4 to number 13, and she has quite a few implants, but unfortunately the implant is failing, and we know that it's going to have to be removed, especially since she had it previously treated with a laser. It didn't work. The tissue was removed, and a bone graft was tried, and that didn't work. So we know that that's a failing implant, and really the only treatment for it is to have it removed. But you can see that the bone loss is quite significant, and she's starting to develop mobility actually on tooth number 10 and tooth number 12. So that is a really scary scenario, especially since she's already invested so much time and money into it. And the case kind of walked in my door, and she said, "You're going to help me." And I said, "Okay. Which bone membrane am I going to use? Which size?" And so the next thing we do is take the implant out, and we can see the massive defect that is kind of left behind here. And in planning these, typically I'm going to say, all right, how are we going to regenerate that bone? Can we place an implant at the same time, or am I going to leave it and let it heal and then put an implant in? And we decided to get stability. If I said, if we can get the implant stable, I will place the implant for you, and we'll graft around it and we'll let it heal. And she said, okay. So we did end up achieving stability of the implant. And this is after all the granulation tissue and everything is cleaned up. So you can see the bone is quite a bit better looking than it did look like on the x-ray. She does have some nice bony peaks, and again, that plays into my decision process on whether or not I'm going to be able to obtain quite a bit of vertical bone and horizontal bone as well. And that then plays into my feeling of, can I get success with the implant at the same time? Because it can be quite risky. If you don't think you can get success, you need to build the bone first. This is with our allograft in place, and again, I utilize PRF and PRF membranes over everything, so we can kind of see that it's a little bit hydrated in bone. It helps it be a little bit stickier to the graft. This is with our laminar plate sutured into place, and after I do this, so this is actually before I close it. After I do this, I go back and I look to see where the membrane is touching the teeth, and I kind of get it away from the teeth a little bit, just to ensure that there's a nice soft tissue seal that's going to happen around the teeth. So then we get our primary closure, and we leave. In certain situations, I'll use PTFE, and in certain situations, I'll use other types of sutures. But my main go-to can be glycolon, and I typically like to use that suture material just because it's quite helpful in maintaining its stability and not unwinding over time or under pressure. So the biggest key to these two when you're placing these is just to have that passive tension-free primary closure. And as par for the course, I did utilize connective tissue over the top of this, and then sutured everything with primary passive closure. And this was taken roughly 2 weeks after. The tissue still looks a little bit gnarly, so we did not take a photo, but the case itself is going to heal quite well. And those were kind of the well-documented that I had. I also had some honorable mentions that I maybe had some x-rays of, or I took some intraoral photos that weren't 100% great, but I think it was a good idea to show. And so this first case is a case that we were doing vertical and horizontal guided bone regeneration. The patient desired an implant, site number 19. And as you can tell, there is a significant amount of vertical bone loss and horizontal as well, which you'll see in some of the photos. You can also tell on just a view of the CBCT here that the bone plate here is quite devoid. And this is a cross-sectional image. The implant height the platform would be off, and there's not enough bony support to buffer biological health of that actual implant. So this is what it looks like intraorally, and again, like I said, this isn't a fully well-documented case. I did use an intraoral camera for this. After tissue reflection, we can see that cupping that kind of comes from when you have a long-standing vertical and horizontal defect there. So we do our cortical perforations here, and we make our periosteal pocket, which is down here. And then I will take the larger laminar membrane and I will kind of wrap it over and utilize that pocket to stabilize the membrane while I'm suturing it into the periosteum. And so that's kind of what it looks like when I'm doing it. And then our passive-free tension-free primary closure. And the biggest way to get that and be successful for it is to do your mattress sutures first. Obviously, if you have been doing this, you probably know that already. It's probably not, it's probably more of a rookie tip, but truly to get a nice sound bite of tissue to allow for a good continuous sling suture. And this case was done about 3 months ago, so I don't have a lot of follow-up on this patient yet. The next one was a case where we are in jeopardy of losing both the molar and the premolar here. And his hygienist had been telling him that this tooth was loose and there was a problem with it for a long time. And he decided not to come back to the hygienist. And a year later, this is how he wound up when he went back in for a cleaning and forgot that he had had a bad experience. So they sent him over to me, and I again said, okay, what type of laminar membrane am I going to use? And about 3 months later, these are the results that we obtained. Just all of that vertical bone was regained, and we actually regained what I would call, again, I can't call it this because I don't have histology, but what looks like a regeneration of a connection apparatus to that tooth. And then the last one, this patient presented with quite a bit of lingual bone loss on tooth number 23, tooth number 23, 24, and 25. This is what her 3D cross-sectional image would look like. She did have some buccal plate loss as well, but really not that significant. The lingual plate loss was just quite extensive, and this just kind of gives us a volume view that she did lose quite a bit of bone on the lingual surfaces of the adjacent incisors as well. And again, intraoral camera, so we can kind of see how much of the bone loss we have here. I mean, it was almost to the apex of the tooth. So I did try to place an implant at this junction, but the implant was not stable, and so I did not feel comfortable leaving the implant. I took the implant out. We utilized our 1x2 centimeter membrane, and we flapped that over with connective tissue and got primary closure. And this was our X-ray kind of at the end of the procedure. This patient actually is coming in tomorrow for a 3D scan, so sorry I do not have that, but I am pretty confident with maintaining primary closure of that wound for so long that it's going to heal quite well, and our results from the procedure are going to be quite good. So that's kind of the cases I have for you guys, and I'll definitely take some questions here in a minute on some of the techniques that I utilize. I think I'd like to answer some of those questions if you guys have them. But really what I would like to say that you guys should take from this, I think periosteal slings for the fixation of this membrane are the way to go. Obviously, tacking is okay. You can do that as well. Personally, I think it's a little bit faster and a little bit easier to use the periosteal slings. So that's typically what I do. I like to hydrate it in PRF, and I also like to hydrate my allograft in PRF. I utilize a lot of connective tissue to bulk the soft tissue prior to implant therapy, because we need to have soft tissue for support of the implant, not just bone. I also like to utilize PRF membranes just to make sure that I have that added extra barrier of biologic properties to kind of keep some bacteria away from the wound that may support it to heal earlier. But really, have caution in your takeaway from this, guys, because again, I said I'm not an expert. I am just a humble periodontist that has been utilizing this with some, in my opinion, pretty good success. So I hope that you can take it away and become great at utilizing it as well, and maybe have it as another arrow in your quiver, per se. So from what I can say without histology, the results I've obtained appear to be high quality, viable bone, biologically stable and functional implants. What I would need to verify those results, obviously, would be histological evidence of the vital bone percentage obtained. And eventually what I will have will be long-term results of how the bone membranes and allografts with implants hold up over time. At the end of the day, though, we're only as good as our patients are going to let us be. So one of the cases that I showed you guys the night of, she decided to pull her lip out and ask me if the surgery had gone well. She wanted to look at it, and I specifically state to all my patients, please do not pull on your lip. Please do not look at it, because that is going to put tension on the wound. Fortunately, the wound healed just fine, but we will have some failures if our patients are not compliant. So thanks, folks. I'll go ahead and take any questions that anyone might have right now. So throw them at me, and I'll see if I can answer them. Okay, so it looks like the first question from John, the question is, did you also tack the membrane of the palatal aspect of number 14 in case 1? And the answer to that is no. You can tuck these in as long as you're planning to have primary closure of the wound. So for me, you can suture it in too, but if you are planning to have primary closure and at least some of it is fixated, or you have it kind of fixated in your periosteal pocket, you're okay to get primary closure over it and it won't move. I really hope that answered your question. Case 2 from Giuseppe. Was laminar bone wrapped around bone from the buccal to the lingual as one membrane? And in case 2, it was not. No, I actually utilized PRF again and just closed it right over the top. So you can use these as plates to just act as a scaffolding, and then you can use another membrane over the top. I've done that as well. Ossix Plus membranes have worked quite well for me in that regard. But I have become more partial to actually folding it over and then suturing everything with a periosteal sling suture. So either way does work, but to answer your question in case 2, the laminar bone was not wrapped around the bone from buccal to lingual as one membrane, but there are a couple cases that I have done that I showed that I did do that. Looks like the next question again is from Giuseppe. So it says, in most cases, is the laminar bone being only placed on the buccal? And no, most of, well, it just depended on the case. So some of them are buccal, some of them are buccal and lingual. So case number 3 was only buccal. Case number 4 was both buccal and lingual. Case number 2 was both buccal and lingual. Case number 1 was both buccal and lingual. Another question from John. Case number 4, 2 separate membranes or 1 across and over the submerged implant? See, so case number 4, no, 2 again, yeah, so 2 and then a PRF membrane over the top. Can you go, okay, so next question from Randy. Can you go over the pilot hole for a tack, instrument to hold the graft? So typically what I've found, I mean, you could use cotton pliers if you're ballsy enough, they do work, but really I have a specific kind of membrane tacking device that I use. and I got that from Meisinger kit, and really it has a pointy end on it, and I will use that to poke a hole into the membrane at the corners. I typically leave about 2.5 to 3 millimeters of space between the pilot hole and the external aspect of the membrane to avoid any type of fracture of the actual membrane. So you can utilize that tacking instrument. You can utilize that to create the pilot hole, but really I use that membrane holding device to both create the pilot hole as well as to hold it in place while I'm putting the tacks in. And typically when I do that, I will get it where I want it, and my assistant will then grab the membrane tacking device, hold it in place, and I will tack. Depending on the type of bone that I'm using, sometimes I'll use the auto tack kit. I've found that somewhat successful in soft bone, but if it's dense hard bone, I mean, that it just bounces right off. So you actually, the Meisinger tack kit is really what I like to use. You can use Profix tacks. I've screwed these into place, but more often than not, if the pilot hole isn't big enough, you're just going to split the membrane. So I've gotten pretty decent at utilizing periosteal sling sutures in my periosteal pocket. So for the most part, I use sling sutures now. There are certain occasions where I'll tack it, but usually those are in cases where I don't feel confident utilizing the periosteum to suture, or we need to gain quite a bit of vertical height, and that bone membrane is just going to bend too much. But typically when I go there, then I'm looking to do a tie mesh or a PTFE membrane. So another question from John. Describe the sling sutures that stabilize the membrane, please and thank you. Okay, so the periosteal sling sutures, I'll kind of go back in my lecture here for you guys. Well, it might take me a sec to get there. Let's see, what is a good way to show you this? Yeah, this one's probably not bad. Okay, so what you see right here, and hopefully you guys can see my cursor. If you can, I'm sorry, I'm just going to be flailing my hands in the air. But what you can kind of see here, what I had described when I first lay reflect my flap, I'll make my initial crestal incision, then I'll make my my incisions around the teeth. I'll do my vertical releasing incisions, and I'll only reflect with my periosteal elevator to, roughly 6 or 7 millimeters, maybe a little further depending on the vestibule for the patient. And then after that, I will do a periosteal releasing incision, which is this up in here. And that will allow then for our flap mobility. And you want to make sure you have tons of flap mobility if you're planning on keeping this primarily closed, because if you have any tension on that, obviously if you've been doing this before, you know it opens. And then what I do after I have my periosteal release and I know I have all that tension or no tension on it, I'll go back and create this, what I call the little periodontal pocket. And typically my membrane will fit right in there. And it'll help stabilize it while I'm doing this. And then the slings that I do are actually just a pretty easy mattress. So you just come in one end, come out, and then you go over and do the same thing in the periosteum on the palatal aspect, bring it back over and tie it. And depending on the size of the defect, I usually will do, I'll do 2 per socket, depending on how big it is. So if I've got a really long or large defect, I'll probably put 4 or 5 of these sling sutures in to keep it in place. So I hope that answered your question, John. Vinay, do you ever use another membrane like BioExclude adjunctively over the top of the laminar bone sheet to enhance soft tissue healing? Really, I use a lot of connective tissue, and again, like I said, PRF. I would say that your soft tissue healing is probably going to be better from a biological aspect if you use soft tissue to let it heal. The BioExclude itself is going to add a nice barrier to bacteria, and might improve some of your soft tissue, but really I don't think the BioExclude is going to help with your soft tissue healing, or increasing your soft tissue. It may help it heal better, but to answer your question, no, I do not. I could see that being a good adjunct though, to create some lack of exposure to the oral environment if you are planning on primary closure, or to create an additional bacterial inhibition zone, which wouldn't be a bad idea at all, Vinny. That's actually a pretty good idea. Thank you. I appreciate that you think it's a good presentation. Thanks a lot. Next question is by Frank. What type of particulate allograft do you use, cortical, cancellous, or a blend? Typically, I use a blend. I tend to find that the inductivity and conductivity of utilizing this allograft is good with both. The cancellous kind of gives us a nice open area for our cells to grow into, and then the cortical provides a little bit more structure for macrophages that are going to come in and turn all that bone over for them to kind of bite on, per se. I know that's not really a scientific answer, but truly that's why I like to use a blend. Okay, what else? Oh, hey, Jen, how's it going? Yeah, we have met. Thanks for watching it. Anyway, next question by Frank. Are you able to wrap the bone membrane from lingual to buccal without it springing back? No, you cannot. So again, that's kind of when I had said there's some cons to this. So you need to make sure that you know where you're going to fixate it and how, and there's some technique to it. So really, when I'm doing this, I have my assistant hold the membrane in place, and I sometimes will even, I'll go back to sharing this case. And in this situation, I will actually prep the sling suture and lay it off to the side. I utilize a lot of retraction for this, and some of the retraction that I use, I'll just utilize the side of it to place the sutures off, so that I can then put the membrane in and then go straight to slinging or to tying the sling. So to answer your question, Frank, no, it will spring back on you. And that is a drawback. Next question by Scott. All the cases you showed had tension-free primary closure. That's actually not true. There are the third case, I believe, where I just had the implant placed in the buccal bone plate loss. There was not primary closure on that. There are actually quite a few cases that I have left them open. Really, it just depends on the patient, the wound type, and how much regeneration I'm planning to do. If it's just a single wall, I will typically, if the implant's stable, I will typically leave that exposed. I have done one where I have left it exposed with both plates lost, but that's getting pretty ballsy. I don't necessarily like to do that. That case is currently healing right now, and it's so far so good. But typically, if the implant is not stable, I will not leave it exposed. Also, in your question, you said, have you left any of your laminar bone cases exposed without primary closure? And yes, I have. Thanks, Drew. Vinay again, can you use laminar bone as a substitute for Corey plate technique? Unfortunately, I am not familiar with what that is, so I don't know. Okay, and then last question. Okay, what antibiotics and pain relievers do you prescribe after surgery? Really, again, it depends on the severity of the surgery, but most of the time, I will put the patient on an antibiotic. Typically, if they're non-allergic to amoxicillin, I use amoxicillin. And then as far as analgesics or pain relievers, I try to stray away from narcotics. I tend to find that a combination of Lodine, 400 milligrams, or Etodolac, 400 milligrams is a trade name, and combining that with Tylenol and alternating those every 4 hours is an excellent pain reliever. And it also has quite a bit of anti-inflammatory properties that come along with it, the Lodine does. So I try to stay away from narcotics. Obviously, some patients are very upset if you don't give them narcotics, and depending on whether or not the patient is truly in quite a bit of pain, I usually will not give them narcotics day of if they want when they come back, and that typically keeps people away from utilizing them. So. Okay, well, it looks like I answered everybody's questions. Thanks, everybody, for tuning in and listening. Hopefully, it was beneficial, and hopefully you guys have some takeaways from it. And if you have any other questions, my information you can just email me at periodoc1000@gmail.com. I'd love to answer your questions. And again, that's PERIODOC 1000 Thanks a lot, guys.
Thank you, Dr. Thousand, for your valuable share of knowledge. We thank everyone for joining us for today's session this evening. As we are slowly returning to our offices and workplaces, we hope everyone continues to stay safe and keep the precautionary measures for the safety of everyone's health. Furthermore, we have some quick announcements. Next Thursday, Dr. Jin Kim will be covering bone graft materials. He will provide a critical review and a much-needed guide for clinicians. Therefore, please register for this webinar at webinar.gdia.com. Furthermore, we are slowly returning to normal business operations, which means GDIA on-site courses are coming back. As shown on the screen, we have 2 upcoming courses. Introduction to Guided Implant Surgery will be offered in both Southern and Northern California. The 4 days implant prosthetic course program covers 4 vital stages of prosthetics, which are occlusion, fundamental, intermediate, and advanced concepts. If interested, please look over the course details at www.gdia.com. We hope you found today's session valuable, and we look forward to your continued participation. Thank you, and we hope you all have a great week.